pandemic and the virus, we all are working towards and adjusting to this new normal, as the word they call it. And the endeavor of Shield is to bring in a lot of educational initiatives for the doctors. And with this, I would like to introduce Dr. Somsekhar Patil sir. Definitely, like Kumar sir said, sir needs no introduction. Sir is very well known. Sir is our beloved teacher. However, I will just say a few words. Sir is a consultant obstetrician and gynecologist from Miraj, Maharashtra. Sir is a gold medalist with MD exams from Karnataka University. Sir is the lecturer and consultant Government Medical College, Miraj. Sir is presently running a postgraduate institute for CPS PGO from the last 15 years, though that demonstrates Sir's tremendous passion for teaching. And I had a couple of opportunities to hear Sir as well. Sir has participated and presented many papers and been a faculty at various state, national and international conference. If you look at Sir's special areas of interest, they are vaginal surgery and high-risk pregnancy. So with this short introduction, without further ado, I hand over the screen to Sir. Welcome, Sir.
Good afternoon, all of you. Thank you, Dr. Kiran, for the good words of introduction. And I welcome all the delegates. I know it's a post-lunch session. How much we all remain awake, let us see, because we are also going through a very unique phase of our life, that is the COVID and the lockdown. Many of us must have had a very unique experience in the life. Like many other pandemics in the past, as we have gone through successfully, I strongly hope that we will also overcome this COVID-19 pandemic and the problem. Coming to the today topic, endometriosis, diagnosis and management, the enigma. Somehow we obstetrician gynecologists are dealing with many enigmas. If we recall, the pregnancy-induced hypertension is also an enigma and still it remains an enigma. PCOD is an enigma and continues to be the enigma, and so is the endometriosis. To define, endometriosis is a chronic estrogen-dependent, inflammatory, painful disorder in which endometrial tissue grows outside the uterus, outside the normal endometrial cavity. Most commonly involves ovaries, fallopian tubes, and tissue lining the pelvis, as well as the bladder, bowel, vagina, or rectum. This endometrial tissue thickens and bleeds just as normal endometrium does during the menstrual cycle. So the lesions go on increasing with each menstrual cycle. As we just now discussed, the sites of the endometriosis are, one is the pelvic sites, another is the extrapelvic sites. In pelvis, as we discussed, the tubes, ovaries, and if it affects the myometrium, we call it as adenomyosis, a special variety of endometriosis. Peritoneum, uterovesical folds are very favorite of the endometrium. Then cul-de-sac, pelvic side walls, the bladder, and the rectum. In extrapelvic endometriosis, gynecological sites will be vulva, vagina, and cervix. Non-gynecological sites will be bowel, lungs, and pleural cavity, skin, especially the episiotomy or other surgical scars, lymph glands, nerves, and brain. So even the distant organs are also involved in endometriosis. This is a picture of the sites. Now coming to the etiology, this again is a disease wherein the etiology is exactly not known. Although signs and symptoms of the endometriosis have been described since 1800, its widespread occurrence was acknowledged only during this century. One thing we know for sure is endometriosis is an estrogen-dependent disease. There have been three theories which have been proposed to explain the histogenesis of the endometriosis. Right from the beginning of the endometriosis, the same theories have been proposed and still the same remain true till we find a real theory to explain all the varieties of endometriosis. First theory is the ectopic transplantation of the endometrial tissue, that is the retrograde menstruation through the fallopian tubes. Second is the coelomic metaplasia, epithelium getting changed to the endometrial epithelium. And the induction theory, the epithelium gets induced to get transplanted into the endometrial cells. But no single theory can account for location of the endometriosis in all cases. Some of the theories will only explain some particular types of endometrial lesions, but all these endometrial lesions cannot be explained by any one single theory. If we go a little more into the etiology, the retrograde menstrual theory was proposed by Sampson's. That's called as metastatic theory. Endometrial fragments are transported to the peritoneal cavity through the tubes, and viable cells from that blood, they get implanted and they grow. So the one good example is the young girls with the obstructive Mullerian anomalies have endometriosis almost universally. Coelomic metaplasia theory. Original coelomic membrane transforms into endometrial tissue, and this explains the endometriosis in ectopic sites. Then the lymphatic and vascular metastasis also occurs. The lymphatic and hematogenous spread of the endometrial cells by embolization, and then extensive communication of the lymphatics between the uterus, tubes, ovaries, and pelvic and vaginal lymph nodes, kidneys, and through the umbilicus. Now, as with all the diseases, the recent investigations are directed towards the investigation of the genetic factors, and endometrium is not an exception. The risk of the endometriosis is 7 times greater if a first-degree relative has been affected by the endometriosis. This factor strongly suggests that the endometriosis has a genetic basis. Also, a multifactorial inheritance has been postulated because monozygotic twins are markedly concordant for development of the endometriosis. Hence, a worldwide collaborative project, the Oxford Endometriosis Gene Study, has been organized to identify the genetic basis for the endometriosis, and let us hope in future we get the exact locus of the endometrium on the genome, and we will be able to get some breakthrough in the management. Continuing with the theories of the pathogenesis, once the lesions start, what are the changes that occur in those areas? Substantial evidence suggests that endometriosis is associated with a state of subclinical peritoneal inflammation. So inflammation is one of the marked pathology that occurs in the endometrium. Peritoneal fluid volume is increased. Peritoneal fluid white blood cell concentration is increased. Inflammatory cytokines are increased. Growth factors and angiogenesis promoting substances are also increased. And macrophages or other cells may promote the growth of the endometrial cells. Because of this inflammation, fibrosis is one of the main features, and adhesions form around the lesions. And this fibrosis, unlike others, these are the intense fibrosis, and the adhesions are sometimes very dense and very difficult to deal with. Continuing with the pathophysiology, of late, many other findings have been noted. Recent research has suggested the involvement of immune system in the pathogenesis of endometriosis. In general, 11-8, tumor necrosing factor alpha, and interleukin 10 appear to be elevated with endometriosis. A recent study showed that women with endometriosis have higher levels of IL-B, IFN gamma, and IL-4, showing a shift towards increased inflammatory cytokines. So this also could as well be considered as an immunological disorder. And endometriosis, as we know, is almost lasts throughout the fertile period. And like the immunological lesions, probably it also has remissions and exacerbations as well. Now, the role of estrogen. Through the beta receptors, it increases the levels of Mullerian inhibiting factor. MIF increases the levels of the PGE2, and PGE2 is the master pathogen in the pathogenesis of the endometriosis. So again, the involvement of the prostaglandins. After going through all these matters which are still to be researched, let us see what is the practical problem with the endometriosis during our day-to-day practice. Nearly 6 to 10% of the women suffer with endometriosis. 4 out of 1,000 women are hospitalized for the purpose of the endometrial treatment. Prevalence rate of 20 to 50% in infertile women, but it can be as high as 71 to 87% in women with chronic pelvic pain. Prevalence of 1 in 10 women during the age between 15 to 55. So considering all this, nearly 25 million women suffer in India due to endometriosis, and it differs from area to area as well. And not only in our country, the endometriosis is prevalent in almost all countries. So we can also call it as a pandemic. So I'm sure once I say the pandemic, all of you will probably be very sensitized because we are going through a pandemic right now. The incidence is on rise, whether it is due to diagnosis and looking because of the laparoscopy, we are able to see more and more minor endometrial lesions, or it could be due to the change in the lifestyle, late marriage, less pregnancies, and affluence. Prevalence is very high during the reproductive period, and younger women, especially less than 30 years, they constitute more than 50% of the total women that are affected by endometriosis. And that is the prime reproductive period of the life, and it can lead to incapacitating symptoms like pain and disability, and of course, the infertility, thereby affecting the productivity in the life. The American Society of Reproductive Medicine has given a classification for the comparison and to know the efficacy of the treatment plans. So there are 4 stages, 1, 2, 3, and 4. They also can be called as minimal, mild, moderate, and severe. And this is given a scoring system, like 1 to 5 is minimal, 6 to 15 is mild, 16 to 40 is moderate, and more than 40 score is a severe stage. Stage 1 consists of a small spots of the endometriosis seen at laparoscopy, but no clinical symptoms. Stage 2 are the mild endometriosis, score between 6 and 10, scattered fresh superficial lesions. They are not, they are on the surface lesions, and no scarring below the surface, or no retraction or the addaxial adhesions in stage 2. Stage 3, it comes as a moderate one, score is 16 to 40. It contains endometriomas which are less than 2 centimeters in size, and minimal peritubal and periovarian adhesions. The stage 4 or the severe one includes anything beyond this, that the lesions more than 2 centimeter and involving more adhesions and more fibrosis, where the score was above 40. Now coming to the clinical presentation of the endometriosis, pain is the main symptom of the presentation. There is a classical triad of dysmenorrhea, dyspareunia, and deep-seated pelvic pain. The pain or the dysmenorrhea commences before the onset of menses, and it continues throughout the menstrual period, and it also sometimes continues even after the menstrual period is over because there is a fresh blood accumulated in the lesions. So this is also called as a pan-menstrual dysmenorrhea. And of course, because of the cyclical changes due to menses, the pain also has a cyclical nature. Deep dyspareunia is usually due to stretching of the involved tissue during the intercourse, especially the uterosacrals. And there is a fixity, and uterus gets retroverted because of the involvement of the uterosacrals and the rectovaginal septum. If it involves the bladder and rectum, there can be other symptoms like dysuria and dysphagia as well. After the pain, next symptom is the bleeding, and it may include premenstrual spotting, polymenorrhea, and menometrorrhagia. Third important symptom or the problem with the endometriosis is infertility. Infertility is present in majority of the women with endometriosis. It is because of the advanced disease leading to adhesions and fixity, resulting in structural damage to the tubes and ovaries, impairing a tubo-ovarian motility. Ovarian problems also are there, and that leads to anovulation, luteinized, unruptured follicle, and oocyte maturation defects. Tube can get affected in the form of altered tubal motility and disturbing the ovum pickup of the natural tube. Peritoneal factors can also add in the form of intraperitoneal inflammation. In addition, there are sperm factors causing phagocytosis by macrophages, inactivation by antibodies, and also at the endometrial level, the luteal phase defect and the implantation defects. So even if it doesn't affect directly, the disorders that are there in all the stages of the fertility process. So in short, the clinical symptoms are dysmenorrhea, pelvic pain, dyspareunia, lower abdominal pain, backache, painful bowel movements, especially during menses, painful urination, which increases during menses, pain with exercise, difficulty in conceiving, and of course, various abnormal bleedings. Now, let us consider about the diagnosis. And as the disease is difficult in all the stages, it also poses difficulties in the diagnosis. So here, the history gives history is important. It gives an idea, and we need to think about endometriosis when we are taking an history and we are expecting the endometriosis. Examination of the scar or the mass, which is tender, and the pain typically increases during the menses, in especially the scar endometriosis. A speculum examination can show a vaginal lesions, and a bimanual examination can give a good information in the form of retroversion, fixity, mass, and the adnexal tenderness. If we suspect clinically, of course, there are helping hands from the imaging science. The classic chocolate cyst of the ovary is the result of blood-filled cavity within an endometrioma, that is the chocolate cyst. Ultrasonography and magnetic resonance imaging can be helpful in diagnosing endometriosis, but not complete. However, neither can diagnose small peritoneal implants, surface lesions, or the adhesions. Although transvaginal ultrasonography is highly accurate in diagnosing ovarian endometriomas, hemorrhagic cysts account for a significant false positive rate or a confusion regarding the hemorrhagic ovarian cysts. Per rectal probe can highlight the lesions in POD and rectovaginal plate. So we may have to use particular probes, or an experienced sonologist can come to some conclusion by using ultrasonography alone. The transvaginal scan, the findings will be retroverted uterus with obliteration of the cul-de-sac and bilateral complex adnexal masses. The TVS helps to differentiate endometrial cysts from other complex cysts like the dermoid. Endometrial cyst typically shows a ground glass appearance, whereas dermoid has got an acoustic shadowing due to solid objects present in the dermoid. So this one picture I've just taken to show the typical endometrioma, or what is called as the ground glass appearance. If not sonography, then what about the CT scan and the MRI? CT is not much useful as far as the endometriosis is concerned, but MRI is definitely useful in accurately delineating the lesions and diagnosing the lesions in tricky areas where the USC cannot reach, like the pouch epidoglus, rectosigmoid, rectovaginal plate, the bladder, and uterosacrals, etc. But still, the surface lesions and adhesions may not be seen with any of these images. So these are few pictures to show the MRI, which how it is a pathognomonic of the endometrioma. The details will be much understood if we are doing the MRI like T2 images and etc. Especially the uterosacral involvement of the endometriosis is better delineated by the MRI. Bladder involvement, especially the bladder endometriosis, rectosigmoid colon, and the colon endometriosis are all better diagnosed by the MRI than the sonography. Of course, MRI can also show the vaginal deposits of the endometriosis, especially which are in the subepithelial area. So the next diagnostic modality is the laparoscopy, and laparoscopy forms a gold standard in not only the diagnosis but also the management of the endometriosis. During laparoscopy, entire pelvis should be examined systematically in clockwise or counterclockwise direction in whatever way that we can have a fixed protocol, and we should see that we don't miss examining any of the areas. Aims or plans or the advantages of the laparoscopy is not only for the detection of the endometriosis, but biopsy of the lesions can be done if there are other lesions which are confusing. Staging of the disease can be done better with the laparoscopy. And most important is the concomitant laparoscopic surgical management. The very typical images directly seeing with the laparoscope one can make out, and those who are doing laparoscopy can easily see these lesions like chocolate cysts, the dark lesions, the dark tarry lesions, the red and the purple surface lesions, and so on. Now, once we diagnose, the question is about the management. Again, because we do not know the etiology, so management also goes on revolving with various modalities. That is, drug treatment can be started for endometriosis, minimal invasive surgery can be done, open surgery can be done, and we can combine these modalities to our advantage so that our aim of treatment is fulfilled. Estrogen has been shown to support the growth of the endometriosis, while the progesterone and androgens induce atrophy. Hence, the main part of our treatment plan in endometriosis is therefore is to decrease the estrogen and to increase the progesterone or the androgens in the body. As far as the management is concerned, it all depends on whether it is symptomatic or asymptomatic. There is one group which is mild endometriosis, wherein there will be no symptoms and we see the lesions only on laparoscopy. Such patients, there is no need for the active treatment and they can be observed over next 6 to 8 months. And in the meantime, the treatment of the infertility can be done energetically. And symptomatic cases, of course, as we discussed, either drug or surgery, we have to plan according to the lesions and the symptoms. Coming to the drug therapy, there are various drugs which are being tried in the management of the endometriosis. First and the foremost is the combined oral contraceptives. These can be administered intermittently or even continuously. There is no need to produce cyclical menses by stopping the oral pills. High incidence of side effects is a problem like thrombosis, embolism. If we are using it for
Yes. Sir, we can see your screen. I think the audio is connecting.
Yeah.
Sir.
I think we were near the treatment.
Yes, sir. Yes, sir.
Back to the. Okay. Am I audible?
Yes, sir. Yes, sir. Absolutely. Sir.
My video is there?
Yes, sir. Yes, sir.
Okay. Sorry, friends. We had some disturbance. So we will continue and try to finish in time as much as possible. I will go through the remaining part. We are now discussing about the drug treatment. I have told about the combined oral contraceptive pills, and I was discussing about the progesterogens, which are the mainstay in the treatment of the endometriosis. How the progesterones act is they exert an anti-estrogenic effect, and their continuous administration causes decidualization and the endometrial atrophy, and that is our aim. So norethistron in the dose of 5 milligrams to 20 milligrams daily or in divided doses, depending on the weight of the patient, or a dedrogestrone 10 to 30 milligrams daily can be given for 4 to 6 months, or it can be even done a cyclical way. This hormone does not prevent ovulation and is suitable for a woman who is trying to conceive, whereas the oral pills will not be useful if the patient is wanting conception. Of late, the Dynogest, which is a designer drug in 2 milligrams daily for 4 to 6 months, has shown very good results. Continuing with the other drugs like danazol, which all remember that during our post-graduation, this was or about 25 years before, this was the mainstay of the drug that was used in endometriosis. A synthetic derivative of the ethinyl testosterone. It's mildly anabolic, anti-estrogenic, and anti-progestational as well. 200 to 800 milligrams for 3 to 6 months, starting on first day of menses, was being used. The side effects were the weight gain, hirsutism, excessive sweating, muscle cramps, depression, atrophy of the breasts and vaginal epithelium. And because of the same reasons, this was not became popular, or it was not continued to be used. Further, the recent drugs are the aromatase inhibitors like the letrozole 2.5 milligrams or the anastrozole 1 to 2 milligrams daily for 6 months. They are anti-estrogenic and prevent conversion of the androgen to the estrogen. And they should be given with vitamin D and C and calcium to prevent the osteoporosis. And nausea, vomiting, or the diarrhea could be the main side effects. Further, the drugs which mainly are used in infertility setup, etc., are the gonadotropin releasing hormones. GnRH is administered continuously to downregulate and suppress the pituitary gonadotropins. It causes atrophy of the endometrial tissues, thereby suppressing the endometriosis. The synthetic analog of GnRH is given in the doses of 10 to 20 milligrams intravenously twice daily, or there could be different protocols in the different centers. Prolonged GnRH therapy over 6 months causes hypoestrogenism and menopausal symptoms such as hot flushes, dry vagina, and urethral syndrome and osteoporosis. Hence, the GnRH analogs are used mainly as adjunctive to the surgery for a short period. One more promising drug is RU486, that is mifepristone, because we all just now have studied that angiogenesis is one important pathogenesis in endometriosis. This mifepristone is angiolytic. Hence, it has been tried at the dose of 50 milligrams daily for 3 months, and it reduces the pain and delay the recurrences. So mainly useful in the symptomatic management of the endometriosis. So in spite of all the drugs being available, there are still failures of the drug treatment are very high because the drug cannot penetrate the fibrotic tissue which forms around these endometrial lesions. Ectopic endometrium responds less to hormones as compared to normal endometrium. And of course, the side effect of most of these drugs is that they prevent conception, and infertility is one of our major concern. So we must remember that the cure is unlikely in endometriosis, and it is almost a disease which lasts longer as much as a fertility period continues, and recurrence is almost sure. Hence, the plan is to control the growth, relieve the symptoms, and manage the infertility. So, if the drug treatment is not going to help, then we are going also with the surgical management in the endometriosis. So, the indications being pain is not reduced with the medical treatment or the drug treatment. Infertility is better supported with the surgical management of the endometriosis. And if there are endometriomas, or especially if the masses which are bigger, which are likely to damage the ovary, it is better to operate on them. And pelvic adhesions, of course, which cannot be treated by drugs, have to be released by surgery only. Moderate or severe disease, which is distorting the anatomy, has to be restored with the surgery. Of course, in infertility setup, a laparoscopy preliminary to the management is very much useful because it removes the uterine fibroids and removes the
Hello,
Yes,
Dr.
sir.
K.
Sir, you're audible. We can see you.
If you're unmuted, I will continue.
Yes, sir. Please, sir. Please, sir.
Okay. So, friends, again, sorry for the inconvenience. Continuing with our matter, I was discussing about the advantages of the laparoscopy in management of the endometriosis. One important advantage, as I told you, is the magnification so that we can better visualize the subtle lesions, less tissue trauma and desiccation, smaller incisions, speedier post-op recovery, and less post-operative adhesions and complications. Then how this surgical management is going to help? It reduces the in the pelvis. It reduces toxicity to embryos and gametes. It enhances uterine receptivity, and it restores the anatomy, that is tubo-ovarian relationship. It restores spontaneous ovulation in after managing the endometriomas, that the ovary is free of the endometrioma. And associated pathologies can also be treated at the time of the laparoscopy, like myoma, hydrosalpinx, and other adhesions as well. The pain relief is one of the main aims of our management. So see and treat if identified at laparoscopy. Consider ablation or excision of the peritoneal endometriosis to reduce the pain.
I think Dr. Patil is trying to share his screen now. Some Wi-Fi issue in Miraj, Maharashtra.
Hello, am I audible?
Yes, sir. Yes, sir. Please, sir.
Then you are audible, sir.
Okay. Adhesiolysis and excision of the lesions improves, then we may have to go for the definitive surgeries than the conservative surgeries. As far as the ovarian cysts or the chocolate cysts are concerned, instead of drainage and coagulation, it is better to do a cystectomy, which will have a better pain relief and a lower post-operative recurrence. Cystectomy is associated with lower recurrence if it is done by surgical removal than the CO2 laser vaporization. In surgery, Ooper also is considered if there is an evidence of the functional ovarian destruction, if there is a lot of destruction, and also if there is a chronic incapacitating pelvic pain and fertility is not desired in these patients. Of course, the hysterectomy is not an answer for the endometriosis because the bilateral salpingo-oophorectomy may also have to be considered because the endometriosis is estrogen dependent, and till the ovaries are present, the endometriosis is going to recur. So case selection is very important. And lastly, the open surgery is not very frequently used in the management. According to WHO, that there are benefits in long-term use of whole medicinal plants because we do not know the exact cause and all these drugs do not help. Many other drug therapies have come into the vogue. So there is a need of our to explore alternative options, and some of them are also coming in the markets. So we have four important problems: is to immediate relief from the pelvic pain or the menstrual pain, to reduce the inflammatory markers, to re-establish the balance between the estrogen and progesterone, and suppression of the endometrial lesions. Hope I am audible in these last few slides. So sorry for the inconveniences, all the audiences. I don't think we can go for the question and answer session with this disturbances. So
Okay, sir. Okay, sir. So, Dr. Kiran here. Thank you so much for a very patient hearing. Sincere apologies for all the technical snags. Sir is almost, sir is done with the slides. Sir is just logging back again for the Q&A session. So, just a couple of minutes, we'll start the Q&A. Meanwhile, if you have any questions for sir, you can probably type it in the chat. Include.
Hello.
Sir, you're back. Welcome back.
Yes. There are audience still?
Yes, sir. Yes, sir. Everybody's still there.
Okay. So almost I have done.
Yes, sir. Yes.
So if there are any questions, then in next 5 minutes we can discuss.
Sure, sir. Sir, there are a quick couple of 3-4 questions already popped in. So I'll just read it to you and you can answer. Is that okay, sir?
Okay. Okay.
Yes, sir. So the first question is, can we use dipomedroxyprogesterone for women who have completed children? What about leuprolide?
Medroxyprogesterone is the long-acting progesterone. That is the one which they have asked probably. So the injectable progesterone, which also is being used as a contraceptive, also can be used in endometriosis, definitely.
Right.
But usually it is in combination with the other, like as a adjuvant to the surgery, or after the surgery we can use, or especially if the patient is elderly, we can use the medroxyprogesterone injection. And of course, the leuprolide is a GnRH analog. It is used in the management of the endometriosis.
Right. Okay. Thank you, sir. So the next question is from Dr. Mamta Devi Suresh. She asks, post-lap surgery, how long will Dynagist be prescribed?
For how long?
This drug, post-laparoscopic surgery, how long should be prescribed?
Yes. Okay. Post laparoscopy, of course, if there is an immediate need for infertility, you can reduce the duration of the treatment. Otherwise, a 3 months treatment would be a better option.
Right, sir. So the next question is again from Dr. Mamta Devi. I think she means in this kind of endometriosis patients, how frequently should the follow-up be done?
In endometriosis, when you are treating, it depends on what are the symptoms that you are treating for. So usually a monthly visit, a monthly follow-up,
Okay.
because one is assessment of the symptom relief has to be done, and second, whether that is consistently going on or not. So monthly visit till she remains asymptomatic for 3 months, and then you can distance the visits.
Thank you, sir. So the next question is from Dr. Amrit Gupta. What are the indications for using decapeptyl depot?
This is an injectable for especially the patients who are not tolerant with the oral drugs, and those who are not compliant, and those who are difficult for the follow-up. In those patients, and especially the post-operative, after the operation, to sustain the effect for longer time, that can be used.
Hello, sir.
Yes.
Yes, sir. So the next question is from Dr. Usha Rani. In terms of management of endometriosis in case of young girls, what would be your comments on that, sir?
If they are of the bigger size, like more than 2 centimeters, as we discussed, the surgical management will be a better option. But considering the age and the unmarried status, we may start with the drug treatment and use the surgery as an adjuvant if there is no relief or no improvement with the drugs.
Thank you, sir. Sir, Dr. Veena Rani has a question to you. I'll just unmute her. Ma'am, you can go ahead.
Yes, Dr. Veena, are you there? Hello.
Dr. Veena Rani? Okay. Probably she's ma'am, can you unmute yourself to ask the question? I think she's not there, sir.
Probably not able to unmute.
Okay, sir. There's one question from Arati, sir. From your opinion, what would be that one clinching diagnostic mode to rule out endometriosis in young girls with severe regular cyclic?
What is the starting point of a question?
Yes, sir. Sir, Dr. Arti asks, what is one diagnosis which can be clinching to rule out endometriosis in young girls with severe regular cyclical dysmenorrhea?
Okay. So I would put it as an MRI. MRI will help us to differentiate because she's an young patient. We may not go for the laparoscopy, which is a gold standard. Very next would be an MRI with an experienced radiologist.
Right, sir. Thank you, sir. So probably we'll take one more question before we wind up. That's okay with you.
Okay.
Yes, sir. So there's one question from Dr. Kumkum Saini. She's asking if you are doing ovulation induction and on day 7, we find that the patient has got bilateral endometriotic cysts. The size of these cysts are about 3-4 centimeters. So she asked, in this situation, should we cancel the cycle or continue with it?
As far as the infertility management is concerned, I'm not doing an extensive work in infertility because I don't run an IVF center or so. So in such particular states, by 7th day, there will have been some recruitment of the dominant follicle. And after that, treating would not yield much results. So if there is an abnormality on the 7th day, it's better to abandon the cycle. And if there is any infertility specialist in the audience who is running IVF center if they are able to throw some light, I would be definitely happy.
So there's a compliment from Dr. Amrit Gupta. Thank you, sir. Nice presentation.
Yeah, I can see that. I can see that.
So Dr. Mamta Devi thanks you for clarifying her question also.
Hope so.
So, sir, I think there are no further questions. Anybody who gives a question, probably I'll send them by email to you, sir, if that's all right.
Okay. Okay.
My great pleasure in having you, sir, as always. And it was a great learning for me also about endometriosis, a subject which is so dynamic and so difficult to understand, sir. So you made it very simple.
Yes.
Vast experience and your passion for teaching, despite so many technical snags, also you came back to give this great lecture. So I'm sure the audience also enjoyed a lot, sir. Thank you so much once again on behalf of Shield Healthcare.
Oh, because this is something, webinar is something very new, even for me. So we had some technical difficulties like teething problem. So hope we will overcome these and further webinars would be much better.
Easily we can do that.
I thank all the audiences for the patient hearing and the Shield, all the team Shield for giving me an opportunity.
Thank you, Dr. Somashekar Patil. Thank you, esteemed audience, for your valuable time.
So thank you. I'll be the leaving meeting now.
Sure, sir. Sir, there are a lot of requests for the presentation. So we are actually recording this session. With your permission, probably we can share the recording, sir, the audience.
Yes, very much. No problem. No problem. So the PPT that I had prepared, has it been all recorded completely?
Yes, sir. Yes, sir.
Because the slides which were there, some of them are added and some of them I have deleted. Maybe this one presentation which I have used now, if that has been recorded, it's well and good.
Surely,
it can be shared.
Sure, sir.
Okay.
Okay, sir. Thank you so much.
Thank you, sir.
Bye. Thank you. Bye, everybody.
Yeah.
Subramanian is there?
Yeah.
Yeah. Where are you?
Hyderabad.
I see. Your camera also is not working. I think I'm not seeing you.
Yes, sir.
Okay. Thank you again.
Sir, have a great day, sir. Thank you.
Thank you. Thank you very much. Bye, everybody.
Bye, sir.